Good morning, everybody. Happy Friday and welcome to class. We are in the end of week 4 and I am super excited today because we have a guest lecture and I'm going to introduce the speaker in a minute. But before I get to do that, let me allow a couple of you who are joining now to get the time to log in and be comfortable. And for the speaker's sake, I'm going to explain also how we work things here. People, when they have questions, they would go and write things in the chat session, especially today. That will be an important thing to do. Otherwise, we'll be muted. I would encourage every one of you who are comfortable to turn on your cameras and participate. And what you usually do is start the day with a warm-up question, and today is no exception. I'm going to ask the question, and you will start to participate, and you will do that while I introduce the speaker, and maybe you may take a second or so to think about the question that you would be participating in today. The question for today is this: what is your favorite or intriguing health metric? You may want to think about it a little bit, but something that comes to mind quickly is just a fine answer. Always, we pick somebody to volunteer to write the question of the day, and Tyler is going to be the man for the day for this job. So Tyler, when you're ready, go type the question for the day. What is your favorite or most intriguing health metric? That's the question, and everybody can start to participate. All right, while you do that, I am going to introduce the speaker for the day. Stefanie Watson is our speaker. I have asked her to give a lecture today, and she agreed to do this. And let me say a couple words about Stefanie. She works as a data scientist for the Institute for Health Metrics and Evaluation in Seattle. You might have heard this has become part of the thing that is happening now. I've heard it in a couple of times in the news. And so they do things that is very much related with data. And so that would become a good reason for having Stefanie on board today to give a lecture. I have always wanted to have somebody who could enhance the lectures that we have by having a real-time example of what they do in their life and how they relate to this class. Stefanie will be particularly interesting because she is a recent graduate of WSU. She got her master's in biology in the School of Biological Sciences here at WSU. And she has taken this same class, but when it was in its formation, more or less. In 2017 fall, she took this class. And one of the things that I liked about her being in the class was she was one of the people outside computer science to take it. And as you know, we have semester projects, and that year's one of my favorite semester projects came out of what Stefanie and her team partner at that time did around food clustering and finding out how things could be healthier, for example, beyond what they could be found by just looking at their nutrition content and things like that. So when I asked her to give a lecture, it was a short notice, so I'm very grateful that she agreed to give this lecture, and it fits nicely into the time we are in. And so the first question I asked was, can you give a lecture? It'll be exciting for the class. And the second question was, can you do it very quickly so that it fits into the schedule I have? I'm talking about data wrangling and data manipulation, and visualization is going to come next. And I think this will be the perfect Friday for doing it. And so she didn't have a whole lot of time, but she agreed. And so I'm looking forward to that. So use the chat session. This will be just as usual how we will do things, but that will be what I would be watching out now because I will not be speaking. And so if you have a question, drop it in there. I have posted a version of the slides that might be useful because you follow along, and I did that on Blackboard. But what I would encourage you is to follow along what Stefanie would be doing, and then maybe come back and take notes on your own and things like that. All right, that was my introduction. Stefanie, welcome, and take it from here.
Hello, everyone. I will attempt to share slides now. And you can all hear me okay?
Yes.
Great. Love it when technology works. Whoop. And then I start on the wrong slide. It's always a good start. Awesome. Thank you so much, Asifa, for that great introduction. I cannot see your chat right now, but I will look for questions at the end, or feel free to call them to my attention as we go. as Asfa said, this is a quick presentation that I've thrown together, and there will be acknowledgements at the end, but I'd just like to quick thank everyone who volunteered slides for me to use. So my name is Stefanie. I work as a data analyst at the Institute for Health Metrics and Evaluation in Seattle. We are somewhat between industry and academia, where we have a lot of faculty on staff and a lot of people who are not on staff at all, but I do work for UW, and we are largely grant funded, which is really exciting because our deliverables are papers and working with collaborators and getting to answer some really interesting questions. So I am going to talk, once I get the slides working, there we go. I'm going to talk kind of about where I work, what is our institution, what are our research areas, specifically the global burden of disease, which is kind of our flagship program, the local burden of disease, which is where I started, but is ending in this September, and then kind of more in depth how I actually work with data intake on my new team, demographics, and on my previous team, working on coronavirus. Then I'll finally have questions at the end. Okay, so IHME takes a variety of people in our mission. So I'm a data professional. We're on here twice because we're that important. And we have a variety of people within our teams. My team right now has a project officer, a researcher, 2 modelers who are doing all with the modeling. Within the data professionals, I'm a data analyst. That means I work mostly with code, with a lot of working on diagnostics, data intake, producing figures for papers. We also have data extraction analysts who work even deeper with the data and extracting it and prepping it for the modelers. We also have an entire pubs team, which is helping us publish a paper right now. We have engagement staff to deal with our network and to deal with questions that we get from anyone. So it's definitely a team effort. We also come from a variety of disciplines. I have 2 degrees in biology. Our newest post-bachelor fellow has a degree in biology, but there are plenty of people who have worked in public health, in literature, accounting, math, and have had a variety of jobs amongst these disciplines. Our voiceover artist, she's great. But there's also been people who have gone from bartending to working in pubs, from traveling around the US to working with me on coronavirus. So we have a variety of really great people. One of the other great things about GBD is that it truly has become a global effort. So we have a variety of international collaborators who give us feedback on our papers, who help us find data, who help us find surveys, and a lot of this would not be possible without them. I will say a lot of these GBD slides are from the GBD 2017 round. So this number is actually pretty outdated. I think we're over 5,000 or 6,000 collaborators right now, which is incredible. Okay, so our research areas, I'm going to talk about the global burden of disease, the local burden of disease, but we also have future health scenarios, which makes our projections to try and predict what health scenarios will look like up until 2100. This is really important for things like under 5 mortality, where the World Health Organization has created sustainable goals for countries to meet. And so we make projections to see if we think countries are going to meet their goals or if they are going to need more interventions. We also have an adoptable health interventions team, a research tracking team to try and estimate how much money is going into global health. Mathematical sciences and computational methods keeps track of our infrastructure. We have a lot of data, and that takes a lot of computing power and a lot of internal databases and shared functions that we need. And then we also have impact evaluations. Okay, The global burden of disease, from here on out, I'm going to call it GBD, is, whoop, there we go, an iterative study. So we put this out once a year. It is annual, semi-annual. We're still working on GBD 2019, trying to get that published as we are finishing up GBD 2020 right now. It's updated regularly to try and include more diseases and health outcomes. And we add new surveys and new data every year. So we try at first to model all-cause mortality. That's just how many people died. We also have a causes of death, and that's what they died from. There are a great number of ICD codes that indicate what someone can die from. And it's very important that we know all of them and keep track of them. We also, that's for mortality, we also model risk factors and non-fatal outcomes, so morbidity. Then in the middle, you can see that we are estimating YLLs. This is years life lost. So when you are born, you have a life expectancy, and you may die before you reach that life expectancy. And the gap between when you died and when you're expected to die is your YLL. We also have DALYs, which are the YLLs plus the YLDs, which doesn't make sense why they're in this order. So the YLDs are the years lost to disability. So if you had a healthy life and then had a disease that caused you to have decreased quality of life for an amount of time, then those years would be your YLDs, and we would add the YLDs and the YLLs to get the DALYs. And then there's also health adjusted life expectancy, which is your life expectancy adjusted based on your expected health. Okay. This is all things that have been added over the last 30 years that we model. And so we have right now more than 100,000 sources. We get all kinds of surveys, censuses, vital registration. Vital registration is very important to me, and I'll talk more about this later. But in a lot of countries, they will keep track of birth records and death records. This is sometimes, we also have a whole team devoted to estimating how complete vital registration is. So take that with a grain of salt. We look at administrative data, we look at disease registries and surveillance. A lot of countries that don't have vital registrations will have disease registries. We look at hospital data, newspapers, news outlets, and police data, because we are trying to go all the way back to the 1950s. Okay. We have 918 geographic locations. This includes 195 countries and territories, as well as subnational locations. So subnational will be smaller administrative districts, such as states, counties, that kind of thing. We use 5-year age bands, as well as smaller under 5 aggregates to estimate. We right now estimate male, female, and both sexes combined with 359 causes and 87 risk factors. So this is an example of what our plot, diagnostic plots might look like, where we will show the factor that we are looking at, the health metric that we are looking at in this first one, which is percentage of deaths due to diarrhea, the location in Costa Rica from 1 to 4 years old. Okay, so you can see we have our data from a variety of sources. We cannot tell what sources we're looking at right now, but variety of sources from 1980 to 2017. And we model a regression for that year. And the blue is going to be our upper and lower confidence intervals. You can see on the right, we now have percentage of deaths due to maternal hemorrhage amongst Nicaraguan women, 25 to 29 years old. And we don't have data from 1980 to 1988. And this is where our modelers come in, and we will have a wider confidence interval, but use covariates and use modeling based on passage of time and age to estimate what we're looking at. If you want to see our results, then we have the GBD compare online. This should be easy to search. I think you can just do GBD compare, I'm hoping. And this will show you a variety of our results. So here we're showing a tree map of global, both sexes, all ages, 2015 DALYs. So we can see that LRI, lower respiratory infections, was a large health risk during this year, and something that a country or something that a Ministry of Health may want to review and look at how to reduce the impact. We have chart titles as a way to look at and see and navigate. So these will always tell you exactly what you're looking at. And if you click on the left, there's a display that shows causes, risk, deaths, and whatnot, as well as various ages, different charts. And they will always have this title showing what the cause you're looking at, what sex ID you're looking at, what age group, year, measure, and unit. Okay. So these are the plots that we show. We have overall maps, which are great for comparing country level results. So your Ministry of Health, or you're just interested in knowing how your country compares to other countries in the area or around the world. We also have the tree maps, like I just showed you, which are great at showing risk composition. We have risk by cause. We have arrow diagrams, which are great at showing changes over time. So you can change the years on either side and see in 2000, perhaps cardiovascular disease was the #1 cause of death in a country, but in 2019, it was the #3 cause of death, and cancers had become the #1 cause of death. We can also have pyramids, various patterns, overlap maps, heat maps, plots, and line plots, all for different purposes. So it's really important to think about how people are going to be using your data, what they're going to need to see, and then provide them these options. Okay. This GBD is my new team. The local burden of disease, LBD, is the team that I started on and was on the longest. So our maps on LBD look a little bit different. We measure at a much finer granularity. So our goal was to map our locations in 5 by 5 kilometer pixels to show kind of exactly what was happening. In this map, you're seeing the prevalence of exclusive breastfeeding. If an area is grayed out, that is because we either were not able to get enough data here, or in this case, there is not enough of a population living in some of these zones where we were effectively able to model. So our goal was to create a geoposition data set, which I will have a link to at the end, and create these higher resolution maps and interactive data tools to be more focused on what is happening at smaller administrative units for policymakers. Okay, so here's an example of vaccination in Nigeria. And so you can see here that national or even subnational can hide health variation. So we look at this 5 by 5 kilometers. We can see that in the north, we have lower vaccination, and in the south, we have higher vaccination. But as we aggregate up into administrative districts, we lose this granularity. And by the time we get to national, you would assume that the whole country has okay vaccination, when the case is truly that some areas are meeting their vaccination goals and some areas are really struggling and could use policy impact. Okay, so our data comes from similar sources, except we always had to have data that was geopositioned, which really limited what we had access to. We used any geopositioning that we could find. Essentially, the gold standard, was CptS, so that we would be able to know exactly where the person reported their health condition or their where the mortality had been reported. And then we used a variety of admin levels that differed per country. So again, we had a whole team that was focused on maps and focused on trying to determine what an admin 2 would look like in various countries. So in this case, we always had national as our highest aggregation. Anything lower than national would be admin 1. So in the US, that would be states. Anything lower than that would be admin 2. In the US, that would be counties. And so on. As you can see, as time went on, we gained massive number of points, polygons, and surveys. Okay, so our methods start with data collection plus covariates, and then some geostatistical modeling done by our modelers until we have estimates of under 5 mortality. That's what I worked on, so under 5 mortality. Okay. So geospatial data has a variety of ways that it can look. As I said, our gold standard were points, so GPS coordinates, and that in general was slightly off for anonymity or aggregated for anonymity, but was giving us our best resolution. We also had polygon data from surveys where privacy was very important, or where they did not have the infrastructure when they collected the data to always be collecting latitude and longitudes. So they would just note where, what state, county, district they were in when they collected the data, and we were able to map these using ggplot. I love ggplot. And then we were able to use population as well to estimate where points would have come from the polygon. So we actually turned our polygons into points and then used those points to create rasters. These are essentially just pixel level data where each pixel here represents a 5 by 5 kilometer, and each pixel has an estimate based on what points were in that raster. So we did this for the covariates as well as the outputs. Okay. Once we had rasters, we were then able to aggregate up into admins 2, 1, and national. Okay. So here's our data coverage, and I really appreciate this plot as showing how 2 different plots can work together to show the data. So on the left, we have a time plot that is showing for each country what year each survey was from, the type of survey, and whether it was point or polygon. The data types here, CBH stands for complete birth history, SBH stands for summary birth history. They're different. They are not super important for this presentation, but if you have questions, feel free to ask later or email me. And then on the right, we can show over time how data composition has changed in a more visual manner with our points and polygons, showing which countries are likely to have the SBH, which takes less time and less money to produce, and which countries are likely to have CBH, which ones are likely to have polygons, and which ones have points, and how that changes over time. Okay, so the geospatial question, as well as whether we're doing this nationally or subnationally, is how do we fill in the predictions for where we have no or scant data? So we look back on our map, there are definitely areas where we have no data in early years, or we have no data in later years because it hasn't been released yet, but we still need to produce estimates for those years. So we will borrow strength from covariates. So we used for under 5 mortality, access to healthcare, maternal education, urbanicity, and other things that have been shown to influence child mortality. We can also use spatial trends based on if a raster pixel has a value, one next to it should have a similar one, a more similar value than one that's farther away. We can also use temporal trends as well as age trends. Okay, and this requires a lot of domain knowledge in knowing what age trends are going to be important in under 5 mortality versus in adult mortality. So our results are all available as an interactive data set at the URL there. And here we can see another interesting thing about working in global health is that we do sometimes have to deal with politics. So you'll see some areas have been grayed out to create holes in our maps. In a lot of cases, this is either we were not able to get data approval from that country, or we were not able to use vital registration from that country. And we knew vital registration would give us the best estimate possible, and we didn't want to release estimates without that information. Okay. If you are interested in this data, there's another link to the visualization tool. We also are gather compliant, which means that all our data and results are available. And you can go to this link and you will be able to find our raster files. They will open in R. Python doesn't like them. I know they'll open in R. They will open in ArcGIS. Good luck with Python. We have our aggregated to admin 1 results, admin 2 results, and our point level estimates, as well as the massive amount of code and our data source list. Okay. So the team that I'm working on right now is demographics. So I've moved from under 5 mortality to mortality in general. And I am specifically working on all-cause mortality. So this is the estimation of the number and rate of deaths by age and sex. Okay. If you'll remember, we estimate in 5-year age groups, as well as a terminal age group of 95 plus, and a number of under 5 age groups, as well as male and female sexes, as well as both sexes. Okay, so most of the data that I look for has already been sourced for us, and our data service specialists have collected it, collated it, and put it into our database for us. So this GHDX is a repository of data on health outcomes. So any of the surveys that I talk about should be available or findable here. There is disease surveillance, healthcare expenditures, our demographic data, our fertility data, and there's the link. So I use right now mostly survey data, vital registration, and reports. So survey data will often be sent to us in stata files or in CSVs where someone has gone and knocked on people's doors and asked them questions about, have you had any siblings? Of the number of siblings that your mother has given birth to, how many have died? And so on with a variety of questions. We also use vital registration, which, as I said, a lot of countries will track death records and death certificates as well as birth and birth certificates. There are also reports. If a survey does not provide the raw data, then we can go look in the reports and try and find the tables ourselves and extract them by hand. So this is what all-cause VR looks like for us, and it presents a number of challenges, including language barriers, different variables, different age group intervals, and all of this needs to be standardized. Okay, and this is, I do some of this work. We also have data extraction analysts that do the bulk of this work. And so eventually it needs to look like this. So you'll see in the second case, we have overlapping age intervals where we have 0 to 1, 1 to 2, and then it goes to 0 to 5. And that would create double counting, so we have to remove that. We have age intervals that we don't model, where we don't model 4 weeks to 3 months. So that needs to be aggregated up and so on. And eventually it will look like this so that this raw data can be updated into the internal database. And we will have standardized locations, years, sex IDs. We will know what the source was so that we can go back and look at it if needed. And we will have standardized age groups so that it'll be able to model. Data is then further processed to remove outliers, subtract shocks. Shocks are non-violent events that we are not able to model or predict. Apply any transformations that are source specific, and remove duplicates before it ever reaches a modeler. Okay. So from March, early March to mid-July, I was on our COVID team. And I started right when they started data seeking. So we started working with COVID because we are a UW institution, and the UW Health, like medical center, asked us to try and track their data. And once people realized that we were capable of it, started to ask us to track more and more until we started doing global data. So at the beginning, it was just a few of us, and then we built structure within the COVID team. Okay. And we had data intake, which did all of the data input for all of the various modeling teams. I think my mic cut out. We did development as well as production data intake. So whenever new results were produced, we were always 2 steps ahead trying to get data for the next countries that we wanted to model for. We had a covariates and production team that was trying to build our covariates out so that we would be able to produce estimates where we didn't have a lot of data. We had exploratory methods and modeling as we tried models and got feedback from people on Twitter and from collaborators to how to make our models better and avoid some assumptions that we had to make early on in order to get some working models at the beginning. Okay, we also had a very large, lovely engineering team who was working so hard to try and help us move away from a manual system. Okay, so data intake had a lot of challenges. All of the data intake that I've talked about for demography so far has mostly been collected by third parties. So someone in the country has gone ahead, done the survey, produced a report, and then released it a year or two later once they've had a chance to look through everything and essentially make the results nice for us. That was not the case where we were trying to quickly get data from primary sources that had just gotten it a few hours before. We were trying to get data from places that did not have the infrastructure to set up and collect. A lot of hospitals didn't have a lot of states and hospitals didn't have websites to report this information. Formats were constantly changing, especially at the beginning, where states would create a website, realize that it was broken or that they could put more out there or that they had more data, change the website again. So there were no standards at the beginning, and even now there's not a lot of standards. And there's a lot of retroactive changes as formats constantly change and as definitions change. So they would find that someone who had been reportedly had died of COVID had then gotten a negative test back, and then you would find negative deaths within the data set, or you would find a hospital hadn't set up the pipeline to report, so then you would have them reporting 200 deaths in one day that were actually from over the last month. Okay. So data seeking at the beginning went a lot like, what data do we need? What data is available? Where can we find it? And how can we share it to other people who are trying to do the same thing? And this was very iterative as we would go searching Ministry of Health websites with the intent of finding case data, realizing that most countries were reporting testing data, and then go back to the, well, if they're reporting testing data, can we use this? Do we want it? Finding that we did, and then going back and collecting all of that. Okay. So the data that we were looking for were largely at the beginning cases and deaths and social distancing measures, which are government orders for gathering restrictions, business closures, that kind of thing. Hospitalizations, if someone's in the hospital, are they in the ICU? If they're in the ICU, are they on ventilators, so that we could estimate hospital resource use, as well as mask use and testing data. So our sources a lot of times were government websites and Ministry of Health sites that had taken over reporting cases and deaths. We also used a lot of governor offices to try and find social distancing measures, especially since we wanted to make sure that we were looking for orders and not recommendations to be consistent. We also had to use social media sometimes. There are some countries that are only reporting cases, or we're only reporting in July, cases through Facebook, which is very surreal to go to your job and log into Facebook to look for coronavirus cases. We also utilized our collaborator network. So as I said, we have some 5,000 people throughout the world that we were able to leverage and send out surveys asking, in your country, what distancing measures have you seen? Where are you finding this information? What day did all business close? All the businesses close. What government site should we be looking at to see this? And our output has been a variety of papers, online visualizations, we have downloadable data sets, and Git repositories. Okay. So a little bit more about some of the data we found and the difficulties with it. Social distancing measures was hands down the hardest because we had a lot of trouble deciding what exactly this means. What does physical distancing look like? It needed to be defined in terms of scale and scope. We did say there had to be a government order instead of a recommendation, but a lot of legal bills are difficult to understand, whether it's an order or requirement. We had a political science team working on this as well, going through and reading through them to tell us, no, this is definitely an order versus this recommendation. We also found that these tend to differ across administrative boundaries and had to make judgment calls on if a state does not have any sort of school closure order, but every county within the state has released a school closure, does that mean the state is effectively closed? Or should we be modeling it as open? And this also required making assumptions about impact, where a state could report that, yes, we've closed all schools, or we've shut down all gatherings over 20, but does that mean people are actually following it? The raw data also had a variety of issues as well, as it comes from different languages, different variables, different update schedules, different formats. Where the examples I've given here, Italy has a really great GitHub where you can download all the data straight into R and do whatever transformations you need, print out the data, required no manual input at all, versus places like Arizona where the backend was really difficult and made it hard to create a scraper. And for a while we were doing a lot of manual data collection here, and they were constantly changing how they were reporting it. And Hawaii, where they've always been really consistent with this format, but don't have testing data. Okay, so our interactive data releases are here. We release daily deaths, projected deaths, hospital use, mask usage, and I believe cases still. And if you would like to use this data, our interactive data set link is here. You can download our data and results from IHME from this link. That contains historical data in case you want to check and see how our models have changed over time. Our hospitalization data, CDC stands for social distancing something, probably should be CDM, covariate, social distancing covariate data, and release information. Okay, questions?
That was an awesome tour of what you do, Stephanie, and I really appreciated you were able to cover it and also speak slowly. I hope everybody were able to do the same thing as I have done. If you saw the chat session and then you saw activities there, well, they were mostly me commenting on a relationship to what is coming up on visualization. And I was going to also say there was a point when you were talking about what we just talked about on Wednesday about missing values and how to get back to find them. And so there aren't many things, but there is one question that came that I would like you to address. And this question is about the databases you worked with, whether, and Pinak wanted to know whether you work with relational data, NoSQL, or some other kinds of big data. Do you have a comment on that?
Yeah, we work largely with relational data. I use SQL a little bit in my day-to-day. We do have an infrastructure team that puts a lot of effort into creating shared functions that pulls the data for us instead of having to use the raw SQL. But I find that sometimes a little cumbersome. So I'll sometimes use the SQL. We don't use NoSQL to my knowledge. We do have trying to remember because I was not on this end of the conversation, but I think we use big data for coronavirus because Microsoft offered us a lot of space and we were very happy to use it.
Okay, and they're close by, right?
Different audiences use GBD and LBD. I'm new to GBD. I have not had a chance to really interact with our audience yet. I know that LBD, we have a lot of policymakers come because they want to see that granular impact. I think GBD is used by a lot of people at the World Health Organization and people like that who want to see kind of nationally how each country compares versus LBD. A lot of people want to see within their country where are places that are struggling with under 5 mortality versus where are places that within their country are doing really great and what the different policies they could enact. What led me to work at IHME? I love data. That's just the sad truth here. I really like taking messy, gross data and then making it something that other people can use. And I love doing visualizations. How much of a stats computational biology background did I have prior to doing this job? I did a biology undergrad at a small liberal arts school in San Diego, and it was secretly marine biology because I took all the marine bio courses that I could and did marine biology lab work. Then when I went to Wazoo, I did a thesis in hydrothermal event community ecology and took all the classes that I could in stats and computational sciences. And the biology courses that I took were geared towards estimation and statistics. So both of my degrees are in biology. However, all the classes that I took were kind of geared towards stats and computer science. Are you working on anything to help predict where outbreaks will be? I do not know if I can speak to that. We do have a pandemics team. It was working it was 2 people kind of working in the background on coronavirus since October, November. Then when the outbreak kind of intensified, became a larger team, and now they're building it out. So I don't know if it is within their plans to try and predict outbreaks. Yes, we use a lot of R in our data processing. What other tools do you use, especially in manipulating and exploring the data? I would say our goal is to use R. We have a lot of older data and a lot of older code that is in something called Stata. And it is kind of difficult to deal with. And we're trying to move away from that because most of the people that work here understand or have worked in R. We also have a lot of tools in Python. But again, some teams don't have people that are really proficient in Python. But I believe infrastructure is all in Python. We do a very small amount of SQL. Okay.
So we have about 30 seconds for any last minute questions, but I think, Stefanie, I'm very grateful. You did an awesome job.
Thank you.
And the participation from the class has been great. And this was just in the right time when we need some of the topics and a real-time example of somebody working. And I love the fact that IHME is somewhere in between industry and academia, because that is kind of a good description of what we want to accomplish by having to take this class. We still are academia and we want to write papers and so on, but I also want people to know what happens when they work in industry. And so this was a perfect example for that. So the time is up. Stefanie, I didn't tell you, but this is recorded and it will be available for the class, and I will share. And if you would like to see it, Stefanie's slides are already on Blackboard. We'll stop here. Work on assignment 3. Don't forget that, and it's due on Wednesday next week. I'll see you on Monday, and we will wrap up the data wrangling discussion there. But the rest of the week is devoted to visualization, and Stefanie has done a good lead introducing that topic. So thanks everybody, and have a great weekend. Thanks, Stefanie, again.
Bye everyone. Thanks for letting me talk.